Good morning and welcome to the Public Health and Minority Health Disparities Subcommittee. I'm Chair Delegate Heather Bagnall. We have a briefing today. We have two briefings actually from Shepard Pratt is going to be doing a briefing on the RAND study on mental health care in the United States, and the Deputy Secretary for Behavioral Health from the Department of Health will be giving an update from the Commission on Behavioral Health Care Treatment and Access. We're going to go ahead and start with Shepard Pratt, who of course are leading providers of residential treatment, outpatient treatment, tertiary specialized care here in Maryland. Dr. Trivedi, would you like me to introduce your team, or would you like to do the introductions?
Oh, I can take care of the introductions. Thank you. So first of all, thank you, Madam Chair Bagnall, for the opportunity to testify before the subcommittee. I am Hirsch Trivedi, President and CEO of Shepard Pratt. Also presenting today will be Dr. Todd Peters, who is our Chief Medical Officer and CMIO. As well, we will have Kelly Savoca, who will be joining, who is our Chief Financial Officer for Shepard. Also on the line, we have Jennifer Wilkerson, who manages strategy, Stacey Garnett, our Chief Nursing Officer, and Scott Rose, who helps with a lot of our community programs. In terms of the briefing for today, what I want to say is our sincere thanks to this Subcommittee on Public Health and Minority Health Disparities. One of the things that we do want to talk about today is specifically this RAND report. We are proud to be able to share more about the life-changing care that Shepard Pratt provides to Marylanders, as well as an overview of the study. And so there is a full report, many pages, that a lot of you, I'm sure, have. What I will just say is we're going to provide a brief overview, and we are open to any questions today, but also to come to your offices or have you come to Shepard to learn more about what we do. For those of you that aren't familiar with Shepard, we are the nation's largest nonprofit provider of mental health, substance use, special education, and developmental disabilities programming in the country. As I say that, every year we take care of 80,000 Marylanders across our 160 unique programs across 380 sites that are in 16 counties and the city of Baltimore. We do this in person as well as through telehealth. While we have 2 inpatient hospitals, the vast majority of the care that we provide is within the outpatient continuum, and we are one of the few hospitals in the state that can say that we accept referrals from every single emergency room, admissions from every single emergency room in the state. We serve all ages, all levels of care, and accept all insurances, including those that have no insurance at all. So what's unique about this particular report, which I think is important to point out, is RAND is a nonpartisan research organization. What they do are objective, innovative approaches to problem solving, and they pride themselves on being impartial, independent, and providing expert analysis of complex policy issues. So while we are, yes, presenting the report, the reality is that the words and the content are specifically from RAND based on the research that they have done. So it is meant to be completely free of conflict or bias, and that's why we were happy to work with them. So in terms of what I would say is that right now, as much as we in Maryland are facing this issue, it is an issue across the nation. And when the folks at RAND wanted to study the topic of how to address a new way of thinking about mental health solutions, they wanted to specifically study Shepard Pratt. And that is something that we can take a lot of pride in across the state, so that in addition to things that we already do on the medical side, we are also national leaders on the mental.
Dr. Trivedi, you just muted.
One of the things that they specifically wanted to focus on was how can we provide equitable care as well as effective care for those dealing with mental health issues. So many people still to this day receive no mental health treatment, or mental health services are highly inequitable across racial and ethnic groups. The purpose of the study was specifically to explore how Shepard Pratt's experience, unique history, and current status as a comprehensive specialty mental health provider system can inform mental health policy locally and nationally to address these issues. So with that, I guess what I would just say is we have a number of folks here thinking about, first, we're going to go to Dr. Todd Peters, who's going to cover the clinical side of what we do and what we see as particular strengths. And then we're going to turn it over to Kelly Savoca, who's going to talk about more of the financial pieces. Todd?
Thank you, Hirsch. And thank you, Chairwoman Bagnall, for the opportunity to testify before the subcommittee. I'm Dr. Todd Peters. I'm our Chief Medical Officer and Chief Medical Information Officer here at Sheppard Pratt. By training, I'm a child and adolescent and adult psychiatrist, very similar to Hirsch, and I've been here at Sheppard Pratt for over 5 years. Sheppard Pratt was founded as an inpatient psychiatric hospital in Baltimore in 1853, and we've been proud to serve the community since this time. As you can imagine, over the years, we've had to evolve many times over and continue to do so to this day. For instance, in the early 1990s, as many psychiatric hospitals were closing, Sheppard Pratt made a transition into community-based mental health specialty care system. And we really were able to combine our traditional inpatient services with an array of community-based outpatient and clinical and residential and social services as well. And I would say it was really around that time that Sheppard Pratt truly became this system that we're really talking about here within the RAND report and what we are today. So we know that now that people with serious mental illness often require ongoing social support to maintain stable housing, employment, social functioning, and that these needs really change dynamically over time. And so to do that in the best way possible, we need a strong, robust continuum of care that stems from these diverse and changing needs. Here at Sheppard Pratt, this is things that we think about each and every day. And we have a comprehensive specialty mental health care system. And this RAND report, I think, really helps to showcase how we are a good case study and how a continuum of mental health care can be constructed and sustainably maintained. Whereas most providers are very small and focused on a very narrow set of services, Sheppard Pratt provides a wide range of services at scale, all within a single organization. So being a single organization allows us to best integrate and coordinate care. At the same time, it also really allows us to work more collectively with other healthcare organizations and also the Maryland Hospital Association. So we are, with them at the table and working with the MHA on issues such as emergency department boarding times and patients stuck waiting for care. And so this is definitely something that we really want to focus on organizationally and help Maryland as a whole continue to excel. A large number of these programs that we do have here that comprise the continuum of mental health care, it can be really overwhelming for patients to navigate as well. So one way that we here at Sheppard really try to think about how we want to really ensure that the patients receive the right mix of services at the right time, and that we really want to make sure that this care is not only just uniform, but also coordinated in the best way possible. So we've really leaned in quite heavily on our care coordination services. We also know the importance of data-informed care and really utilize information tracking and exchange. And it's really become kind of a key part of what we do. And really, we've tried to take a field that is sometimes very subjective and turned it into an objective one, and really are trying to use a lot of evidence-based integration frameworks as well throughout our organization. So with all of this, measuring and reporting are important pillars of our integration plan because they ensure that we provide a consistent quality of care across our service lines and hold each part of the system accountable to our same system level standards. So again, a lot of this work is done through our own homegrown systems. Unfortunately, one of the things that really holds us back is that we do not have a united single electronic medical record. We were bypassed in the past. There were for a lot of the meaningful use dollars that were put out there, nearly a decade ago that helped a lot of the medical systems be able to purchase this new technology. There was a asterisk that prevented us as a standalone behavioral health organization from having the same access to that. So we've done as much as we can do to maximize what we have and are really hoping that one day we will be able to get toward a more united single medical record that will hopefully be funded by federal dollars or other sorts of dollars in the future that we just really do not have access to at this time. So that gives a little bit of a detail about our care delivery journey. I want to turn things over to Kelly Savoca, our CFO, to speak a little bit more about our financial focus.
Thank you, Dr. Peters, and thank you, Chairwoman Bagnell, for the opportunity to testify today. I'm Kelly Savoca, Chief Financial Officer for Sheppard Pratt. I think although the concept of continuum of care does receive widespread endorsement, the actual construction of such systems of mental health care services is an enormous challenge. So we think about all of the services that Sheppard Pratt provides. Each type of service is funded uniquely and has variable financial performance, from inpatient services to residential to outpatient to social services. And how this has been managed is really across the country. It's managed at the local level with local policymakers, often at the county level, who work with providers such as Sheppard Pratt, as well as state and federal agencies, to create and manage a viable continuum of care. The greatest challenge is really around ability to provide stable and sustainable funding to provide that comprehensive set of services that meets all patient needs. And research has shown that mental health services are reimbursed at a lower rate than services for physical health. And often we see that reimbursement is not benchmarked to cost or escalated for inflation, and so continues to fall further behind. Sheppard Pratt is really the prototypical example of braided and blended funding, and this comes through in the RAND report. While we are largely government payers, we also have commercial payers and other federal, state, and local funding, along with donations flowing through the organization. But maintaining access to services requires fairly extensive coordination of this funding. The reality is that only about 20% of our services deliver a positive operating margin, so we do a significant amount of subsidizing and investing in services to make sure that the finances flow, allow us to break even, all while maintaining access to programs and services. I think furthermore, the issue is compounded when you have significant operating losses throughout much of your programming. It's difficult to reinvest capital over the 300 plus facilities that Sheppard Pratt operates throughout the state. Just focusing a little bit on the positive and some of the things that really make us in the state of Maryland different. I think our biggest ally in this work has been our size and scale. So it's because of our size primarily that we can operate the services at the scale that we do and take on some risk. One of the examples of this is in the RAND report. It's mentioned Chesapeake capitation. So Chesapeake capitation is a capitated rate program in Baltimore City for high-need individuals with Medicaid. In this model, Sheppard Pratt provides wraparound services, and we're at risk for outcomes as well as to keep people in the community and out of the hospital. I think another advantage, and more broadly, is around the environment in Maryland. Having a regulatory body such as the Health Services Cost Review Commission setting inpatient rates that are benchmarked with annual updates for inflation ensures access to inpatient services. I will note for Sheppard Pratt, as a specialty hospital, this really technically only applies to commercial payers, which is a small percentage of our population. But our largest payer, Medicaid, pays 94% of regulated rates. And while that doesn't always cover costs, we know that this is better than what exists in other states. That, along with Medicaid expansion, ensures that more people have access to inpatient services in Maryland. And then I'll just add another nuance to this. Medicare is reimbursed through the federal model for specialty hospitals. So for us, that's inpatient prospective pay, equates to roughly 70% of regulated rates, which means we do not cover costs on those services through reimbursement. Our largest challenge has really been around rising costs and rates not keeping pace with those. Some of the specific issues that have been highlighted in the report include challenges with adolescent residential services. So the state has seen an exit of providers doing adolescent residential work because of the reimbursement structure. Sheppard Pratt had historically operated 2 programs. We're down to 1. But the state has made some improvements to this model, but there's still a cap on the funding, which creates operating losses and access issues, but it is better than it was before. Another area of challenge is around outpatient and professional-based services, which are underfunded. So last year, Shepherd Pratt provided over 200,000 services between our community outpatient sites, primarily Medicaid and Medicare. And last year, we invested over $3 million in those services to keep access open. How we've typically managed this in the past is that we've had funds that have offset some of those losses. We did participate in the state CCBHC planning grants and hope that the state moves forward with the CCBHC model, which will create a long-term sustainable funding. Another challenge that's mentioned in the report is around sustaining community-based programming that supports social determinants of health. This requires a continued and ongoing investment. So these programs are funded by grants and contracts, but the funding is fixed and there's a cap on indirects and exclusions on what can be included in the reimbursement. And so as the costs increase, we no longer see that funding covering the cost of the service. Due to some of these challenges, we recently had to make some difficult decisions to reduce capacity in our outpatient programs and reduce some of our grant-funded social services in order to ensure that we remain viable. I think the most important thing, though, for you to know is that while we had to make these decisions, we're constantly balancing and focused on balancing financial performance with access. So thank you for the opportunity to speak today. I will turn it back over to Dr. Trivedi to finish the presentation.
Thank you so much, Kelly. We've talked a lot about the benefits that are highlighted of having a system like Shepherd Pratt that are all mentioned in the RAND report. I would say, as many people think about our unique model in Maryland on the medical surgical side, and that's something that the entire nation is looking at as we think about the AHEAD model. Similarly, the entire nation looks at Shepherd Pratt and what we do here as a model for how mental health can be transformed across the nation. In fact, we actually are working with health systems as well as state governments across the country to figure out through our management and consulting services division how other states can emulate what we are doing and actually bring a lot of access that doesn't exist in most places, or the robustness of types of services in our continuum that we offer. We have, just as a point of fact, I will say that we have recently responded to DHA's RFA for technical assistance in developing a children's behavioral health strategy, which is work that we are doing at other states across the nation. We really would like to move the needle on mental health, and particularly health disparities. We would say that we need a coordinated response to address each of the issues across each of the populations. While this is a brief 20-minute presentation, if anyone would like further conversations or would love to come and see what we do in action, we would be more than happy to do so. I do want to leave a lot of time for questions, and so with that, back to you, Chair.
Thank you, Dr. Trivedi, and thank you to your entire team for this presentation. I am going to go ahead and open it up to the members. Delegate Rosenberg.
Thank you, Madam Chair. Dr. Trivedi, you or whoever else on your team, in light of the, I want to salute you on the work you're doing and the assistance you provided on this RAND study. How can we fill the gaps that we have in Maryland, with waiting room care, as I think that's the prime concern at the moment? What advice do you have for actions that the legislature, specifically HGO, can take this session to get rid of such long waiting time? If that is the most important thing we should do. If it's not, tell us.
Sure. I guess what I would say is we very much do agree with the administration's focus on how do we think about a public health emergency? How do we get upstream? The reality, though, is at the same time, we can't do it without forgetting about people that are stuck in emergency rooms at the same time. I do want to turn it over to Dr. Peters, who's been actively engaged in this issue and working on it. So, Dr. Peters.
Yeah, thank you, Hirsch. It is definitely something, as I alluded to earlier, we have been working closely with the MHA as part of the work group focusing on this. You are right that the behavioral health needs of the state are brought up quite frequently in this discussion, because I do think that we have seen time and time again at multiple hospitals that folks waiting for behavioral health care are some of the folks that are waiting longest. We really do have a tale of, I'd say, two cities here within the state. I think we have quite a robust adult-based services, of which, as Kelly alluded to, does have some issues around payments and rates that does handcuff some of what we do within the state. But for kids, we really have a true issue at our hands where we do not have enough of the intermediate services available. I think the way that we see this playing out in emergency rooms is truly more reflective of a backup that even exists in other levels of care throughout the state. We have a lot of individuals, sometimes even 20 to 25% of the kids, even within our own walls, are folks that we would consider waiting for that next step of care and really stuck in our own hospital system. We know that in the residential programs, albeit which are a lot more limited in number than even 5 years ago when I started, there are a lot of folks in those parts of the system that are waiting to either age out into adult-based services or waiting for that next step. We often are faced then because of that backup in the emergency rooms where we recognize, and even the providers there recognize, that probably inpatient level of care for that child isn't really necessary, but there's no other alternatives within the state to send them to. So it becomes a very binary discussion of, do I send them home back to an unstable, unsafe place, or do I admit them and let them figure that out? So what it really does is it really hamstrings us across the board. And I think these are just some of the ways that we have seen some of this backup occur, and definitely seeing that there are some, especially with kids, and even especially with kids with, say, neurodevelopmental disorders or autism, we're even seeing a particular issue there where there's a lot of folks that are getting backed up. We could spend lots more time talking about this more broadly, but I also want to save time for other questions too.
Thank you very much, Dr. Peters. Did you have a follow-up, Delegate Rosenberg?
No.
And I just want to remind the members, for the sake of time, that we do ask one question, and to our presenters, whoever is best equipped to answer that question, feel free to field that question. Delegate Hutchinson.
Thank you, Madam Chair. I guess this would be directed to Dr. Trivedi, and it's sort of something that's been sitting in my mind since most of the HGO committee took a field trip to the Baltimore City Mental Court during the interim. And I recall when the day was wrapping up and we were having lunch with all of the judges, a few of them I felt were pleading to us in a way to say, we don't want to put them in jail, but we don't have another place to put them. And looking at us and saying, we keep seeing hospitals being closed. Is there a way that can be transitioned into inpatient beds? And it made me say, well, wait a minute, weren't we there years ago and we shut those down, and here we are today? So I'd just be curious, your thoughts on that we experienced when we went up there.
Sure. So I would very much agree with the judge's opinion. I think what I would just say is we've had a national movement to decrease the number of psychiatric beds, and I think in many ways the pendulum has swung a little bit too far. What we face in Maryland is slightly different, and what I mean by that is, we were helping the state in managing the ED bed board and kind of making phone calls every day to every emergency room across the state. What the data showed actually is that at any given day, we actually have availability of beds. It's actually the fact that the patients who are stuck in the emergency room are more complex than what a general unit in a medical center can manage. And so I think this is the part where I would say we actually have a robustness of outpatient mental health services. The issue that comes up is when someone is acutely ill and needing more intensive care, yes, you need an inpatient unit to do so. The problem that we run into, and I think what the judges are saying as well, is we don't have the right services for those that actually require the most intensive services. And I think that is something that we'd be happy to follow up with you about in terms of ideas or solutions. But I think you're right. You've hit I'll say the hammer right on the head of the nail in terms of what the inherent issue is.
Thank you, and love to find out more about it along the way. Thank you.
Thank you, Delegate Hill.
Thank you, Madam Chair, and thank you all for being here. And good to see you again, Dr. Trivedi, President, Trivedi. And I think you sort of hit on this. So we've had the issue of beds closing, a period of time in the teens. So, 5 to 10 years ago, we had the courts closing beds, right? Because we didn't have the capacity and we weren't giving the right services in our facilities, weren't there for our forensic patients. So we've got the report and I quickly scanned through it, and they seem to have financing solutions. But the state has been looking at provider solutions, asking people who are non-psychiatrists to take on other responsibilities and people who are not psychologists to take on other responsibilities. And you sort of mentioned that we have this disconnect between the programmatic, needs and the programs we actually have. So I guess my question is, what are the solutions that you think we ought to be focusing on when we talk about our statewide behavioral health system? Financing, that's always an easy ask, but it's a hard thing to deliver on. So what are the other pieces that we might be able to move more effectively on that you think are necessary to make the change we need to make?
So I think that the biggest thing I would say, and I'm intentionally, as you said, keeping the financing part off the answer, is, this is the subcommittee that's focused on public health. And I think that the thing that I would just say is, when we think about diabetes, when we think about any other chronic medical condition, we think about populations of people and how are we going to move the needle. I think when we get to mental health, sometimes a little bit of how we sub-optimize the solution is that we then say, okay, well, this is mental health, so let's not focus in on this incredibly small local behavioral health authority. Let's figure out the mobile crisis piece here. Maybe there's a provider that can do this little bit of piece over there. And I think a lot of what the report is talking about is we can actually do a better job maintaining people in the community by having this integrated continuum of services. And that's clinical integration I'm talking about. The second aspect is, like any other public health concern, when you look at the types of patients with the types of conditions and what they need geographically across the state, I would argue that, yes, there's this belief that, okay, within the HSCRC model, you have hospitals that have excess bed capacity, and somehow they will magically have the skill set to take care of complex patients with, I'll say, severe autism, or that they will take care of patients. And what we find in all of these situations, it's like me going to a general community hospital and saying, okay, well, you have a bed open, go and do a level 1 trauma case. Bad things happen. We have bad outcomes. We also have the staff that are getting injured because these hospitals are not able to take care of the capacity or the severity of patients that are there. And so I think the reality is, for something like that, and that is truly, I will say, tertiary and quaternary care services, no different than on the medical surgical side of the house. You have a provider like Shepherd that can do that work, and we can actually help in putting together a statewide solution to meet those needs so that we don't have people either languishing for care or staff who are unnecessarily getting injured or harmed because they don't actually have the skill set to deal with patients that have pretty complex needs.
May I follow up with Dr. Trivedi?
Go ahead, Delegate Hill. Delegate Hill, you're on mute.
Sorry, thank you. I appreciate that answer, and I think you're right. But the issue is, if we don't have sufficient providers or providers who are willing to do that complex care, because I hear from my psychiatry friends that even though we know what 80% of the psychiatric care is given by primary cares, they're very frustrated by the fact that many of those people should be coming to them because they too are complex and we're not giving the right treatments. We're just giving a treatment. So that's on the outpatient as well as the inpatient. So how do you suggest we get around this right fit issue of the right programs, the right level of training, and the right care? Any suggestions on that, or do we just have to sit down and do some work working on that?
I think the wonderful part of this is, and I think a lot of the report shows it, we actually have amazing programs that are already doing some of the work that we're talking about. So for example, we provide integrated behavioral health services across every GBMC primary care site. And so there are models of integrated care where, yes, the primary care provider can take care of a lot of the more straightforward, mild to moderate illness. But then you also have a co-located mental health professional that can manage the harder cases that come up or help in those places where we need a second opinion. So I think probably outside of the scope of the time we have here, but there are nationally accepted models that exist, which we are already employing right here within the state, that can be scaled to meet these needs and take care of the folks that really are above and beyond what a primary care provider can take care of. And those are all things that could be built into a model for how we advance care within the state.
Thank you.
Thank you, Dr. Trivedi. Thank you to your entire team. And I think this is an excellent segue into our next presentation. As this committee knows, in 2023, we passed House Bill 1148, which was the behavioral health model for Maryland. Encompassed within that legislation was a commission on behavioral health care treatment and access, which was charged with a study of our entire inventory, how our best practices, looking at recommendations from previous reports, looking at best practices nationwide, and making recommendations on how to have a better coordinated, more efficient behavioral health system that meets the needs of our Marylanders. It was a huge charge, and I'm happy to welcome Alyssa Lord from the Maryland Department of Health Behavioral Health Administration. Dr. Lord, would you like to introduce your team?
Sure. So thank you, Chairwoman Bagnell and members of the committee. I am joined by Marie Grant, who is our Assistant Secretary for Health Policy, Sarah Barra, the Chief of Staff for the Maryland Department of Health Behavioral Health Administration, and over in the corner, hiding, is Sarah Case-Perron, who has recently joined the department as our Director of Governmental Affairs. I'll get it right one day. So thank you so much, and good morning. As the chairwoman mentioned, my name is Alyssa Lord, and I have the honor and privilege of serving as the Deputy Secretary for Behavioral Health for the Maryland Department of Health. We thank you for the opportunity today to provide an update on the Commission on Behavioral Health Care Treatment and Access, and thank you, Rory, for pulling up the slides. I'd also like to thank the Moore-Miller administration and the many members of the HGO committee and subcommittee who have been deeply committed to improving the access to and treatment of behavioral health care of Marylanders, and are ardent supporters of the investment in behavioral health Maryland has made in ensuring that we leave no Marylander behind. Next slide, please, Rory. So there are a couple of areas we'd like to discuss today, inclusive of how the Maryland Department of Health is approaching critical systems improvement and redesign, an overview of the Commission, what we have accomplished to date and highlights from the inaugural report, and what the Commission will seek to accomplish over the next year. Next slide, Rory. Thank you. Before speaking about the Commission, I'd like to take a few moments to discuss the extensive redesign work the department is undertaking. And this very much does dovetail with the presentation that we just received from our colleagues at Shepherd Pratt. This involves broad stakeholder engagement, review of the current landscape and that of which is happening at the national forefront, and encouraging both our internal team at the BHA and those of our external constituencies to think about the tremendous potential and opportunities that exist to expand existing and innovate new services for Marylanders. Next slide. Some of you may have seen this framework before, which we are calling the Behavioral Health Continuum of Care. And our vision is a state where all Marylanders have access to high quality, equitable behavioral health care, which you also heard our colleagues at Shepherd Pratt mention. Equity is a hugely important subject that we take very seriously. Our behavioral health continuum of care must include culturally informed crisis services, address ongoing mental health and substance use needs, and support individuals who are re-entering their community. Moreover, we need to set our sights upstream to prevent and address trauma, to promote health and well-being for all of our residents. We must continue to address disparities, build hope, and save lives. What you see here is a framework for a patient-centered whole person model of integrated behavioral health and substance use care, also known as the continuum of care. This model not only aligns with the Moore-Miller administration and the significant financial, programmatic, and staff investments that are being made, but allows for us to think about how individuals and families may need different services across a period of time. The continuum is not static, and each pillar of prevention, promotion, primary behavioral health, urgent acute care, and treatment and recovery do not live in discrete silos. Underpinning the continuum is the core tenet of equity, data-driven decisions and transparency, and maintaining and expanding the workforce, not only within BHA, but also the community. Some of the elements of the continuum are already in place. We do need to maintain them while also being creative and thinking outside the box to build out new areas to ensure we are able to meet Marylanders where they are in a sustainable way. A couple examples of how the continuum translates to reality, and we can talk about this more, but we are actively working towards an extensive and expansive children, youth, and family strategy. Again, you heard Shepherd Pratt mention that they've applied to the RFA that the department released recently. A focus on veterans such as the Hickson grants, and we will be releasing those grants shortly, and suicide prevention, strategies to increase utilization of 988, inclusive of discussions with 911 to ensure seamless connectivity to care, and the release of the crisis notice funding opportunity to support expansion of mobile crisis teams and crisis stabilization centers. So again, these are areas that we are looking to build out in the continuum, much of which you had heard referenced, and even the questions that came up during the prior discussion around how do we build out this network of services so that we are addressing the least to most acute need of Maryland residents. There are a couple of other pieces that are in the pipeline that I want to mention. So the Centers for Medicare and Medicaid Services has recently shared a new 1115 waiver opportunity for states to improve care for individuals leaving jail or prison. And this opportunity will allow states to cover a suite of services for up to 90 days prior to an individual's expected release date. Ultimately, this opportunity can help Marylanders at high risk of substance use disorders and other health conditions to get the care that they need when they are re-entering the community. I am proud to share that Maryland is actively exploring how we can leverage this opportunity to improve healthcare outcomes for some of our most vulnerable citizens. And lastly, we have engaged in exciting and robust partner engagement that will allow us to not only meet the intention of the continuum, but actualize and operationalize services and programs. And this is inclusive of ongoing discussions and investments in community-based organizations, as well as faith-based organizations, community colleges, and HBCUs. Next slide. Just a couple of pieces here. So I joined the department at the end of August and have spent the last several months learning about the many facets of our current programs, meeting with our partners, and brainstorming the exciting future that lays ahead in front of us in creating a world-class optimal system of whole person and person-centered care. Tanya Schwartz joined us, and she is overseeing our expansion of mobile crisis and crisis stabilization under the pillar that is urgent and acute care. Tanya has experience both working at CMS and as a national consultant on issues that range from Medicaid to children's services to the work that she's leading now around crisis. And we feel fortunate to have Tanya on our team. And we have reorganized the organizational structure within the Behavioral Health Administration to better reflect the continuum presented on the previous slide, and have implemented an approach for teams to work interdisciplinary and collaboratively with the goal to minimize silos and enhance service provision across the spectrum. And as mentioned above, we are seeking to establish mechanisms that will support our programs, not just through grant funding. An example of this is our submission of regulations, licensing, and payment methodologies that were resubmitted to AELR in December. Next slide. And Marie, if you want, you can go on to the next slide. We'll actually get to the subject at hand here, which is the commission. So As outlined in the legislation and per the chairwoman's comments, there are 4 key components to the commission. Secretary Harris Scott was named chair of the commission last fall. The purpose is to define and recommend the core set of accessible and equitable behavioral health services to be available to all Marylanders across the lifespan. Ensure extensive due diligence and analysis to understand the landscape of existing and needed services ranging from programs across all populations to financing of services to evaluation and to provide recommendations for future state. The commission is comprised of 4 work groups, which we'll talk about in a couple of slides, inclusive of geriatric care, youth behavioral health, individuals with developmental disabilities, and individuals with complex behavioral health needs, criminal justice involved, behavioral health workforce development, infrastructure coordination, and financing. These work groups are represented by stakeholders across all areas, community members, providers, systems, universities, etc. In subsequent slides, we will discuss the status of each of these work groups. And lastly, provision of the annual report, which was provided yesterday, which also outlines the behavioral health needs assessment. And that needs assessment includes 4 elements. And that's the analysis of morbidity and mortality data as it relates to behavioral health, an analysis of adult utilization data for the public behavioral health system, an analysis of children's utilization data for the public behavioral health system, and an assessment of currently funded services. Next slide, please. So we are fortunate to have wonderful chairs overseeing these 4 distinct work groups. And while they are distinct work groups, there is recognition that the work is inextricably linked and that the recommendations that originate from the work groups must consider how they are woven into the broader behavioral health continuum. So Ben Steffens, who's the executive director of the Maryland Healthcare Commission, chairs the geriatric behavioral work group. I have the privilege of chairing the youth behavioral health, individuals with developmental disabilities, and individuals with complex behavioral health needs work group. Dr. Aaliyah Jones is overseeing our work around criminal justice involved behavioral health with that work group. And last but not least, Commissioner Bahrain of the Maryland Insurance Commission is spearheading our efforts around behavioral health, workforce development, infrastructure coordination, and financing. Next slide. I'd like to just take a moment to thank the individuals on this slide from the Maryland Department of Health. As you can see, it is very much all hands on deck across the Maryland Department of Health to support the commission. And so I am sincerely thankful for those that are helping to support this absolutely critical work. Next slide. And I'd like to just spend the next couple of minutes talking about the hard work that across the commission has transpired in a very short period of time. Perfect, Rory, thank you. So as you saw, Chair, we had the first full commission meeting in November. The work group meetings convened and designated all 4 of the work group chairs, and they have all collaborated to submit the report. As I said, that was issued yesterday. And the report contains recommendations that are for the full commission. And in the interim, we're keeping this work on push, and we are continuing to schedule and convene the work group meetings to meet not only the statutory requirement, but understanding that this work is absolutely essential in moving us forward for how we're thinking about implementing the continuum of care. Next slide. And so during the first commission meeting, the ask was to focus on 2 key tasks, just to give some context for the initial meeting that transpired. So it was reviewing prior recommendations and reports of state commissions, work groups, and task force related to behavioral health care services, and assessing behavioral health care services in the state to identify needs and gaps in services across the continuum, including community-based outpatient and support services, crisis response, and inpatient care. These 2 mandates are viewed as foundational tasks that were critical to guide the commission in its future work. Next slide. So the submission of the inaugural report summarizes the finding of 65 reports that were reviewed in preparation of the commission. The report also highlights the initial behavioral health needs assessment, along with summaries of both the full commission and work group reports. The report also outlines the work that will continue to ensure the provision of a robust network of behavioral health care for all residents. Next slide. As we think about the prior reports and recommendations, and the authorizing statute requires the commission to review prior recommendations and reports of state commissions, work groups, or task forces related to behavioral health care services. There was a significant amount of time and effort spent reviewing the reports to inform the first commission and to make sure that we were being inclusive of the necessary materials to review. We also sought guidance from librarians at the Department of Legislative Services to ensure that our review was comprehensive. But this just gives you a subset of the various different reports that we utilized and provided to the commission and the work groups. Next slide. So in talking about the initial needs assessment for adults, I've already provided the criteria, but just again, it was the analysis of morbidity and mortality data, adult and children utilization of the public behavioral health services, and an assessment of our currently funded services across jurisdictions. And so a summation of the findings for adults include there are fewer providers billing for SUD services than mental health. We see significant disparities in the landscape across the state as it pertains to service provision and delivery within Western, Eastern, and Southern Maryland, representing areas that are underserved by the provider community. And what we are seeing is that, more than 40% of providers are located in Baltimore City and Baltimore County and submitting claims for that service utilization. And then as it pertains to mental health and SUD services, they were most likely to be utilized in an outpatient setting. And for both mental health and SUD services, more than 217,000 individuals access care. Next slide. For our children and youth, so psychiatric rehabilitation services and support services were the most commonly accessed and utilized. It's also where we have probably one of our larger number of service providers. Access to intensive community-based services and supports for high acuity in children is limited. And again, I think we heard about this from the RAND presentation by Shepard Pratt. Regarding demographics, adolescent girls are more likely to access inpatient and emergency department services in comparison to their male counterparts. And as mentioned in the previous slide, for children, we are seeing the same regional variation that we saw in adults as it pertains to accessing care. And so some of this may be impacted by the inability to access services, as well as where individuals or children and families may have to go to seek the care that they need. Next slide. So the initial work group reports, again, came out of a review of those 65 reports across the various different work groups. And what you see here is a summation of the recommendations that came out of those first work group meetings. But just to provide a high level, the overarching themes are workforce, special populations, including those that are aging and adolescents, and those with IDD, and co-occurring behavioral health diagnoses, training, housing, data, provider quality, and innovative reimbursement strategies. Next slide. So we are excited about what the future holds as it pertains to what the commission is seeking to accomplish. And there's a lot of work, as I said, that's ongoing and that we will be spearheading over the next 6 to 12 months. But areas of focus will include new initiatives related to mobile crisis services, crisis stabilization 988, which was also known as the Suicide and Crisis Hotline, and the partnership between MDH and the Community Health Resources Commission and the Consortium on Coordinated Community Support. So we're really looking to figure out how do we collaboratively work across interagencies so that we are building a network of care and leveraging the various different funding streams. And moreover, the commission has agreed that topic areas impacting all work groups will be discussed during commission meetings. And those were the overarching themes that I previously discussed to ensure that each work group has an understanding of other groups' positions and can move forward with recommendations in an organized and coordinated manner. So for the next slide, please, Rory. For 2024, to be responsive to the call for additional voices on the commission, MDH opened up an application process to provide an entry point for those interested in participating in the work group as allowed by statute. 88 applications were received. And we are in the process of reviewing those applications and we'll be making appointments to the work groups in the spring. We will also be updating the claims-based analysis to see if any changes occurred between fiscal year 21 and fiscal year 22, and to continue to convene a review of data and put forth recommendations. Again, harkening back to the continuum where we are utilizing data to make informed decisions. Next slide. So I want to take a moment to talk about departmental actions and next steps. Rory, next slide. Bless you. As you know, the Commission on Behavioral Health Care, Treatment, and Access is tasked with reviewing research and making recommendations to guide the state on providing appropriate, accessible, and comprehensive behavioral health services. The department has requested SB 212, which requires the Behavioral Health Advisory Council and the Commission to have joint meetings, which is already occurring as a practical matter, given that the amount of membership overlap between the two groups. And just for context, our analysis shows that 22 out of the 38 members of the commission overlap with the Behavioral Health Advisory Council. And given the public nature of the commission, we are seeing a significant number of the remaining members who also sit on the Behavioral Health Advisory Council attending the commission meetings. And we've made, obviously, as I said, made those meetings public. This bill would allow for joint meetings and reporting and extends commission reporting deadlines to reflect when the commission was able to start meeting. The bill also requires the commission to research and make recommendations to the Governor and General Assembly regarding integrating behavioral health services into Maryland's Medicaid program. Maryland currently separates or carves out Medicaid financing of behavioral health services from its Medicaid managed care organization. This carve-out, established in 1997 for mental health services, aligned with a national trend at the time that saw carving out behavioral health services as a promising approach to protect funding for behavioral health, establish specialty priority networks who could provide specialty behavioral health services, and mitigate insurance plans from limiting their behavioral health benefits. But again, we've also heard today about the important value that integrated networks of care play in that intersection between primary care and behavioral health. And so, adding this task of researching and making recommendations on integrating behavioral health services is an important next step to determine whether this is the right step for Maryland. Next slide. And I just want to thank you all again for the opportunity to present an update on the commission, and I'm happy to answer any questions.
Thank you very much for your very comprehensive presentation. And I'm going to take a moment and open it up to the members. If there are any questions. It seems it was a very comprehensive presentation because we don't seem to have questions from the members. I just want to thank you again for all of your work and your due diligence and your review of all of the materials that have come before, because I know that was a very big concern and a frustration that we had reports, we had recommendations, and we didn't have a process by which we could compile and collate those reports and recommendations to create a more comprehensive continuum of care. So we look forward to supporting your good work, hearing more about the next steps, and hopefully supporting the recommendations that you have already made. I'm looking at my members right now. Any other questions from our members before we adjourn? Well, thank you very much. Thank you for being here and for all your good work. And to our members of the subcommittee, we have another briefing at 1 p.m. in the committee room and hearing starting at 2. With that, we are adjourned.